Okay, so for the next speaker, I don't even have to have my notes. Dr. Rene Pierpont from Minnesota, and she will talk with us about patient perspective. And Rene and I just realized yesterday that we know each other 10 years. Yes. Okay, here you go.
Okay, so this talk is going to represent quite a shift from the last one, but that's really the beauty of this conference is, basic research, clinical research, patient perspectives, all being in the same session. And I'm really excited to talk to you today. So neurodevelopmental and mental health challenges are extremely widespread, perhaps even the most widespread feature across RASopathies. From sleep issues to behavioral challenges to learning differences, these features are both highly variable and highly recognizable. Although various therapeutic approaches have begun to be tested to treat these symptoms, mostly in NF1, there's a crucial element that has been overlooked in much of our research. We've quantified cognitive and behavioral symptoms and concerns with standardized assessments. We've reported unique neuroanatomical findings, and we've identified key therapeutic targets. But we haven't extensively examined our patients' actual care experiences. Our insights are currently pretty limited when it comes to the types of services patients are receiving and accessing, whether they're perceiving benefits from existing treatment approaches, or what barriers prevent them from receiving optimal care. And this disconnect between clinical research and patient perspectives limits our ability to develop truly responsive treatments for the RASopathies community. Okay. I'm just trying to figure out this part. Advance. How do I advance on here? There we go. Okay. All right. At the RASopathies Symposium 2 years ago, we heard a talk from Dagmar Tiemens sharing research from an important study to identify key themes and topics that RASopathies families felt needed to be addressed. And their published paper included this quote illustrating how neurodevelopmental issues such as social communication, cognition, processing, and behavior were identified by families as important to them and deserving of more attention. And building on this foundation, my research team sought to use similar methods to conduct a qualitative study focused specifically on the mental health care needs and treatment experiences encountered in everyday life by RASopathies families. And essential to this effort was the recognition that developmental and behavioral concerns affect not only individuals with RASopathies themselves, but also their caregivers, their parents. So caring for a child with a rare disease can profoundly transform every aspect of a parent's life, from juggling appointments to navigating educational or financial needs, all while simultaneously demanding they become experts and advocates in their child's condition. All of this juggling can take its toll, which is only exacerbated when emotional and behavioral challenges present. So here's a figure I pulled from a 2016 study of behavior in children with CFC syndrome. And although it wasn't a main focus of the study, one thing that really stood out to us was how dramatically behavioral concerns affected parents of the study participants. The more challenging behaviors a child displayed, the higher their parents' stress levels. These findings underscored, of course, pressing needs for treatments to address developmental and mental health concerns, treatments that could potentially benefit both patients and their families. So when my research team embarked on a study to gather patient perspectives on navigating behavioral health care, we knew we needed to include both patients and caregivers. Before I share our study findings, I'd like to acknowledge the various funding sources that supported this work. One of my former postdoctoral fellows, Ali Foy, received a grant from the Masonic Institute for the Developing Brain to initiate the study, and another team member, Maya Elizondo, was awarded a grant from the Neurodevelopmental Program in Rare Disease. My team's also currently supported by the CTSI at the University of Minnesota and the NIH. I'm also going to mention a little disclaimer that the qualitative approach and methods of the study, which they're just very outside my comfortable wheelhouse of careful measurement and numbers, but I really enjoyed doing the study with a great team to help identify what I think are some useful insights for us to reflect on. So let's shift now to discuss the methods and results of the study. Volunteers for this study were young adults with RASopathies, ages 18 to 28, who asked to meet with we asked to meet with us virtually with a member of our study team and discuss their experiences. We asked them to tell us about their concerns regarding their own mental well-being, the supports and treatments they had tried, the barriers that they'd faced, and what facilitated their care. And we also asked for insights into potential treatments that could be helpful in the future. In addition to these individual interviews with young adults, our team also conducted a series of focus groups with caregivers of children and young adults with RASopathies, ages 3 to 25. And we conducted 4 focus groups, one for each of the 4 most common RASopathies. In total, we enrolled 22 caregivers in the study, in the focus groups, and conducted 11 interviews with young adults. The demographics of individuals who are reported on in the study included a wide range of ages, genders, and gene variants. And while 4 different RASopathies were represented across the groups, one limitation of the study was that this virtual interview format was difficult for some participants, especially some of our patients with CFC or Costello syndrome who had some anxiety about virtual communication or who didn't use verbal speech. After conducting the interviews in focus groups, the recordings were transcribed. We developed a code book based on the literature and our clinical experiences to categorize different themes and ideas that emerged from the participants' information. And this schematic shows the process of content analysis from start to finish. So we used a process of descriptive coding where we reviewed and reached consensus on our coding between multiple researchers. We updated the codes based on newer emerging themes and concepts. And once we reached saturation, meaning not many new ideas were coming from additional transcripts, we began to identify and analyze relationships between the codes. So we analyzed the transcripts to answer the following research questions. We wanted to understand what types of challenges families were experiencing, what treatments they were utilizing to intervene on those concerns, what families saw as getting in their way, or on the flip side, as facilitating treatment. And lastly, what were the themes that emerged when our participants spoke about their experience of developmental and behavioral health care? Focusing on that first question about neurodevelopmental and mental health impacts of RASopathies, I'll first present this graph showing simply the number of times that patients and caregivers reference specific types of concerns. The top 3 concerns mentioned most often by caregivers in the dark red bars and young adults in the gold bars were the same, though in slightly different order. Anxiety, attention and executive function, and mood concerns were the most frequently noted. Parents also frequently mention concerns about anger and conduct, about social development, developmental delays, and behaviors related to autism. And sleep was another concern that came up quite a bit. So, a take home message from this aspect of the study was the prominent impact of anxiety on individuals and families. This is an area that's been touched on in the literature, but it was really striking to me that 86% of caregivers and 100% of young adults mentioned some form of anxiety as having a notable impact on their mental health. And to me, this kind of overall graphic signifies a few areas, which include anxiety, that are really at the forefront for families, but maybe not captured as in many of our clinical studies. So here's a quote from a participant describing what anxiety feels like to them, like feeling shaky, nauseous, experiencing difficulties eating and drinking, and not feeling well physically. So many different presentations of anxiety were mentioned. This is just one example, but a clear impact on patients' overall emotional well-being, their engagement in life, their function, and sometimes even their health. Next, we looked at the various types of treatments and supports that were described by families. Interventions broadly fell in 5 categories, with therapy and medication being by far described the most often. ADHD, anxiety, mood, and behavior regulation, as well as sleep, were the most common indications for psychiatric medications. Therapies included supports for development, like speech therapy, and various inpatient and outpatient psychotherapeutic treatments that focused on social, emotional, and behavioral support. So there isn't time to go into too much detail here. There was a host of other strategies mentioned within family, community, and social systems, as well as individual coping methodologies like physical activities, structuring a schedule, or dietary changes. But within this context, a key focus of the study was to better understand what barriers patients faced when seeking out treatments to meet their needs. This graphic shows the main types of barriers discussed on the left in the kind of peach color, and the aspects facilitating care on the right in kind of a green color. And so in this brief talk, I'll just touch on two barriers that were common to both data sets, both parents and young adults. And those were related to scheduling and adverse effects of medication. So both young adults and caregivers struggled to find appointments with providers due to wait lists and other delays. And both patients and parents reported that medication side effects had been a barrier to continuing treatments that sometimes were effective. In terms of facilitators, it was notable that young adults emphasized that a good fit with their therapist or provider was essential to a good experience. So, to delve a little deeper into that point, I want to share two quotes by young adults with RASopathies who expressed that a lack of provider fit was a big challenge to them in accessing quality care. So these insights that patients shared with us really speak to the need for provider training and education when it comes to working with patients with RASopathies and other rare diseases, and perhaps options for patients to access knowledgeable providers through telehealth or other similar means. I'd like to wrap up this talk with the final part of our analysis, which involved identifying key themes that were discussed by participants with RASopathies in our interview. So I'll touch on the themes and also try to connect it back to the potential relevance for clinical research and trials. So the first theme was related to the complicated interface of physical and mental health symptoms, which I've been discussing with several of you at this conference already. So participants frequently described how physical symptoms like pain, seizures, tumors, cardiac symptoms, joint disorders frequently led to or exacerbated mental health symptoms. So here's one example where a parent saw a major shift in behavior after her son experienced seizures, which lasted even after the seizures were treated. And we heard from Les Rogers earlier today on similar kind of neurodevelopmental effects of experiencing seizures. So additionally, beyond that, patients and families also described how medications for physical health conditions often had unintended mental health effects. So when thinking about clinical trials, this complex constellation of physical and mental health symptoms underscores the importance of accounting for the physical health variables when we conceptualize our treatment approaches, and also considering potential mental health effects of physical conditions in their treatments. As Dr. Blakely mentioned in her talk yesterday, sometimes the worsening of cognition or mental health could be a side effect of a drug, or on the flip side, improvement in those symptoms could be a secondary benefit, even if cognition and behavior are not the primary target. A second theme identified in our content analysis was the shifting and changing of neurodevelopmental and behavioral concerns over time or across different settings. So many participants described an evolution of their symptoms. A parent shared that their child was having, terrible night terrors at age 4, which then evolved into kind of broader anxiety later in development. And this quote here highlights how one participant experienced difficulties specifically in the transition to adulthood and to living independently. So a key takeaway from this description that we heard over and over in certain places, is that certain places or people triggered symptoms, and effective neurodevelopmental or behavioral treatment needs to account for some of these situational factors. So therapeutic work might need to be generalized in different settings, in school versus at home, or treatment may need to target a specific age range or stage of development where symptoms are particularly prominent. A third theme encompassed the experience of feeling different and the lack of community knowledge about RASopathies. This was a huge theme. So some individuals described feelings of isolation, of not fitting in, of having difficulty finding partners and providers who understood them. Caregivers often reported feeling unsure of how to explain their child's condition to others, especially when there were a few outward manifestations of the condition. This theme helps to illustrate that to address the needs of the RASopathy community, it's not just treatments for individual health conditions and symptoms that are needed, though that's of course very important, but broader, it needs to be paired with broader awareness, advocacy, and acceptance. Finally, a fourth theme revolved around suggestions for improving or identifying new treatments and supports. A range of ideas were identified by study participants, but these two examples highlight clear interest in number one, trauma-informed care, and number two, RASopathy-specific or condition-specific resources and recommendations. And this was shared by multiple individuals, young adults, and caregivers in our project. So to my mind, these are specific kind of actionable suggestions that can readily be integrated into clinical training and developed into projects spearheaded by trainees or clinicians with the support of family advocates. What do we do with all of this rich information? It never hurts to leave your audience wanting more, so I'll end by saying that we've developed this work into a manuscript that contains a set of kind of action items in 4 different domains. And these action steps attempt to integrate what we've learned by listening to patient voices with existing knowledge from the current research literature. We call it a set of crucial needs to inform research and care approaches, and I'm happy to discuss these needs with any clinicians, researchers, or family members who are interested. And if you want to talk at this meeting or meet later on Zoom, I'm happy to do so. So I'd like to acknowledge the incredible team that worked with me on this research and express my appreciation of all of our advocacy groups. You're amazing in your recruitment efforts and ability to support our research programs. And thank you also to our research participants. I hope our families will feel that this study has helped to center their voice and their perspective as we move toward more clinical research and trials to improve behavioral health. So I invite any questions or comments. Thank you.
Any questions? Yes.
I'm Easton. I have Noonan syndrome, and it was when did they realize when I had Noonan syndrome? 4 months. Going back to when you said about like the stresses about parents, what kind of physical and mental health concerns could there be about them?
In terms of how kids' behavior can sometimes impact parenting stress, that part?
Yeah.
Yeah, that's a great question. So sometimes there can be behavioral challenges that can hurt. Kids can hurt themselves, self-injurious behaviors. Sometimes there can be behaviors of aggressive behaviors. Sometimes as a parent, it's really hard to see your child suffering. And so if you feel like your child is feeling really anxious, your child is feeling struggling with their mood is up and down a lot. It can be really hard to witness that. And specifically in CFC syndrome, we have a lot of young people who struggle to communicate. We also noted that kids who are able to communicate more with their parents, that really impacted parent stress levels as well. So higher levels of ability to express themselves and communicate what their needs were, that actually improved parents' experiences and helped to ameliorate some of that stress.
I saw one on the back and then Bruce.
Hi, I'm Sarah. My daughter has NF1, and I used to work for a nonprofit organization that worked specifically with children's mental health. And we did a lot of focus on adverse childhood experiences and how they affect the health over the lifetime of an individual. And I love that someone said that trauma-informed care was so important. And I don't know if this is more of a question or a comment, but, in this study or in what you're going to do next are you looking at these experiences as trauma? Because, the multiple doctor's visits, the unknown, being a person with these rare diseases, you sit and a caregiver as well, you sit in so much of that unknown, which is going to drive anxiety up. So I know you mentioned quite a bit about, therapies and drugs, but is there an emphasis on actual early intervention mental health care, like group work, having, coaches, therapists, play therapy, that kind of thing? Is there implications for saying this is happening and we need to have, early intervention work with the parents so that they can deal with the issues that are coming through, because it essentially is trauma and it's going to play out that way. And all those things that we're seeing behaviorally could be coming from those trauma experiences.
Thank you for your question, and we should talk. I would love to hear more about your background, and we need people who are knowledgeable about kind of the impact of trauma and trauma-informed care to be more interested in identifying avenues of intervention for families with RASopathies. It's something we've, Bruce has been here since the very beginning of all of the advocacy groups and has heard many times from families how they're going through traumatic experiences and trauma, and we need to incorporate that. And I think that was a real point that came out in this study, is that yes, we can help families, like I said, with individual treatments, but maybe more so by thinking about how we support families at these critical times when they're going through severe feeding difficulties. They're stressed about medical issues or about their child's behavior and mental health concerns coming up. So absolutely, that is an avenue of kind of next steps, and figuring out ways to study it as rigorously as possible so we can really understand ways to intervene that will be effective.
Bruce?
You want to go ahead? Congratulations, Rene, on venturing into qualitative research. That took bravery. So to some extent, you were contrasting the outlooks of the person, the young adult who's affected with the RASopathy versus their care provider. How much of the differences you're seeing do you believe are difference between those two very different roles, so to speak, versus the fact that the component RASopathies of the two groups was rather different?
I think both played into it. Okay, so I think the age ranges represented were a little bit different. I think the individuals who were discussed in focus groups by caregivers were often individuals who would have had difficulty kind of expressing their behavioral mental health care picture to the team on their own. So I think that some of the caregiver versus patient perspective differences were due to some of those characteristics of differences between the group, and also just the different perspective and insight that a parent has over somebody who's been through it themselves. And I don't think our goal was really necessarily to spend a lot of time contrasting the differences, but to really understand the themes that were coming up for each group individually and both groups together, to sort of uncover what are some of the real concerns and barriers that we're identifying from people who are really affected by RASopathies in day-to-day life.
Really quickly, and we need to wrap up.
Thank you, Rene. Very, very interesting. And, as you know, I treat epilepsy, and, now because of sort of my new kind of entering into the RASopathies world, I'm slowly accumulating a lot of patients with RASopathies and epilepsy. And something I've noticed is that their seizures are actually trivial to manage compared to a lot of the other sort of neurobehavioral issues that are outside of my area of expertise. And my colleagues in psychiatry usually are not well equipped or sort of not really well informed, at least at my institution, but on the adult side of things to really manage these. So this is, I think, really tremendous effort, and particularly I think something that in my attempts have been a little bit of a black box is that RASopathies, particularly CFC, has this additional challenge of a whole host of medications we cannot use that we typically use to sort of manage behavioral issues. So it would be really helpful to have that knowledge base of what's working and what are people using, because, in my own practice, I'm kind of constantly going through this back and forth that there's this whole list of medications I'm familiar with. I cannot use 9 out of 10 of them, right? And that could be really helpful for the providers as well.
Yes, I completely agree. And a study that really examines specific medication use and perceived benefits and adverse effects would be very timely. And I also just, in kind of response to what you said, thinking about some of the talks that we heard earlier today about, feeding in the kind of like team approach. Could be really helpful in this regard of kind of neurology, behavior specialist, neuropsychology. Like if we could kind of bunch together around, supporting families that have these complex presentations. I think that's another thing we should be doing as best we can at different institutions.
Thank you so much. Definitely a lot of interest.